Globally, about 1/4 of all neonatal deaths are caused by birth asphyxia. Birth asphyxia is defined as the failure to initiate and sustain breathing at birth. The birth attendant has about 30 seconds to complete the initial steps before deciding if another intervention is needed. The first 60 seconds after birth are the most critical. The need for resuscitation is often unexpected. Therefore, the person attending the birth should be trained in neonatal resuscitation and be well prepared to make the appropriate decisions at every delivery. On this course, you will learn to evaluate the newborn and to identify 1. When a newborn needs help to breathe. 2. When to assist with ventilation and how to use a T-piece resuscitator to inflate the lungs. 3. When should you stop lung ventilation? These basic procedures will provide you with the skills needed to save the lives of newborns who need respiratory assistance. To start, why do some babies need help breathing? During fetal life, the baby begins to have mild respiratory movements that prepare the baby for birth. If the fetus experiences a significant lack of oxygen before or during birth, these respiratory movements may stop. The cessation of these respiratory movements is called apnea. Initially, the heart rate is normal, but if oxygen levels continue to fall, the heart rate will also fall. If the oxygen levels fall further, heart rate will continue to drop, and if not delivered soon, the fetus could eventually die. If the fetus is delivered during the apnea period, the person attending the birth will need to help the baby breathe and in some cases help to establish a normal heart rate. This is called neonatal resuscitation. We will now see how lung inflation can be used to end the newborn's apnea and restore normal breathing. In uterus, the fetal lungs are filled with fluid. After birth, beginning with the infant's first effective breaths, air progressively replaces this fluid, which is absorbed by pulmonary circulation. When the baby does not breathe spontaneously immediately after birth, this process is not triggered. Therefore, the baby needs help to breathe. Preparing the delivery room is also essential. The delivery room must be warm and free from drafts. This is to prevent the baby from getting cold. A source of radiant heat must also be used. Make sure there is a good light source to assess the baby. This light may be from natural daylight, an overhead light, or a bright flashlight. A level, firm surface and warm, clean towels must also be prepared. Finally, prepare the materials and equipment to be used. A T-piece resuscitator to provide assisted ventilation. Verify that it is working correctly. Masks of different sizes. A stethoscope and a visible clock are both essential in order to evaluate heart rate, and the clock is also necessary to time the delivery and duration of the assisted ventilation. Finally, a bulb syringe or a suction catheter. Either a bulb syringe or suction catheter may be used to suction the airway. Now, please take time to review the list of required materials. Note that in the next segment, the function of the T-piece resuscitator will be explained in detail. The T-piece resuscitator is a pneumatic, manually operated, flow-controlled and pressure-limited device especially designed to facilitate neonatal ventilation. We will now show the different parts of the T-piece resuscitator and demonstrate how to prepare it for use. The T-piece resuscitator requires a gas source in order to function. The device can only function if it receives compressed gas from an external source. This gas may be air, oxygen alone, or a mixture of air and oxygen from a blender. In order for this device to function properly, an input gas flow rate of 8 litres per minute is recommended. The T-piece resuscitator has a gas inlet line and a gas outlet line, connecting the device directly to the patient through a corrugated hose. The T-piece can be connected to a face mask or to an endotracheal tube. In this video, we will only use the face mask. On the left side of the device, you can see a knob hidden by a cap where the pop-off valve is situated. This knob has been preset by the manufacturer, and this course will not cover alteration of the manufacturer's setting. On the right side of the device, there is a knob that allows for adjustments to be made on the peak inspiratory pressure, PIP. A manometer incorporated into the body of the device shows the insufflation pressure. The PIP is generated by intermittent occlusion of the T-piece cap with a finger and can deliver an accurate peak inspiratory pressure breath by breath. For example, if turning the knob clockwise results in a pressure of more than 20 centimeters of water, the knob should be adjusted back to the left in order to achieve the desired inflation pressure. Typically, it is best to begin with a pressure inflation of 20 centimeters of water. This device can deliver positive end expiratory pressure, PEEP. This can be predetermined by adjusting the ring of the T-piece cap. This pressure is used to prevent the newborn's lungs from collapsing. Typically, a pressure of 4 to 5 centimeters of water is used. The PIP and the PEEP are constant for every breath and can be adjusted according to the baby's clinical response. Pressures can be constantly monitored through the manometer included in the device. The duration of occlusion of the hole on the T-piece cap regulates the inspiratory time. Now, please pause the video and take some time to familiarize yourself with the T-piece device and test its proper function. In this segment, we will discuss the initial steps you should follow as soon as birth occurs. As soon as the baby is born, you should start the clock. Remember that the first minute is the most crucial one. You must work carefully and quickly to assess whether the baby is breathing alone satisfactorily or if he or she needs help with breathing. If this is the case, then begin this assisting ventilation as soon as possible. Babies are born wet, and as a result, they can get cold very quickly. This can result in severe complications, including death. Therefore, it is essential to dry the baby and to do so vigorously, because these movements can also stimulate the baby's breathing. Then, discard the wet towels and wrap the baby in clean, dry and warm towels. Remember, it's extremely important to keep the baby warm at all times. When a baby is delivered, a quick assessment should be made of the baby's clinical condition. A healthy baby would establish regular breathing within 30 seconds of birth. The baby should show a good tone. That is, the baby should be actively moving his or her arms and legs. And the newborn's heart rate should be at least 100 beats per minute. If this is the case, then the baby does not need help to breathe. So, when does the baby need help to breathe? To determine whether a baby needs help, you should pose the following 3 questions. Is this baby born at term? Is the baby breathing regularly or crying? Does the baby have a good muscle tone? If the answer to any of these questions is no, then the newborn needs help. A baby in need of lung inflation will not be breathing, will be floppy with very little muscle tone, and will have a slow heart rate less than 100 beats per minute. Remember that every second that elapses makes the resuscitation more difficult. So, if you need help from other people, do not hesitate or delay in asking for it. Important: the heart rate is evaluated through the stethoscope by auscultating over the left chest over the nipple. In order to shorten and facilitate the heart rate evaluation, count the number of beats in 6 seconds and then multiply that value by 10. The next step in resuscitation is to inflate the lungs of the newborn, opening the airway. Please pay careful attention as we demonstrate how this is done. The baby should be lying on a flat surface on his or her back. Place the baby's head towards you for a better visual control and your comfort during the procedure. The neck must not be flexed or extended, meaning that the baby's face is positioned parallel to the surface. Placing a folded towel 2 to 3 centimeters thick beneath the shoulders should help to achieve the correct position. Suction the airway, only if it is necessary. That is, if you suspect that the airway is obstructed and filled with secretions, then proceed as follows. Clear the airway using either a bulb syringe or a suction catheter. In doing this, first clear the mouth and then the nose. A useful mnemonic for remembering this is that they are in alphabetical order. First, the M, mouth, and then the N, nose. The reason for clearing the mouth first is to prevent stimulating the nasal reflex and to keep secretions in the mouth from being aspirated directly into the lungs. We recommend that you put the baby's head to one side, allowing the secretions to collect in the cheek and facilitating their removal. Insert the catheter or the bulb syringe into the mouth and apply suction briefly and gently, taking care not to introduce the instrument too deeply or beyond the mouth, as this can be harmful. If you use the bulb syringe, remember to squeeze the bulb, then insert the tip into the mouth gently and release the bulb in order to suction the secretions. Once suction has been completed, remove the device from the mouth, place it over a towel and then squeeze the bulb again. When the secretions have been removed from the device, repeat the suction procedure on each nostril. Once the mouth and nostrils have been cleared, the next question is, when and how should lung inflation be initiated? If the baby does not breathe and the heart rate remains below 100 beats per minute, you must give 5 assisted breaths. Before beginning this procedure, you must first select the correct size mask and connect it to the T-piece resuscitator. The baby's head must be maintained in a neutral position during the resuscitation process. To accomplish this, use one hand to support the baby's head while administering the inflation breaths. Then, place the mask over the baby's mouth and nose, making sure to cover from the tip of the chin to the mouth and nose, but do not cover the eyes. The mask must be held and compressed with 3 fingers from the top, not near the edges, as this will ensure a good seal around the mouth and nose. This is called C-grip hold. The best way to determine whether the mask is properly sealed is by checking the manometer. If the manometer doesn't rise to 20 when you inflate the lungs, the seal is not correct. Once you have determined that the mask is in the proper position, then begin the lung inflations. Hold the mask with one hand and the T-piece with the other. To inflate the baby's lungs, occlude the T-piece cap with the thumb or the second finger. Removing your finger from the cap will result in exhalation. Continue occluding and clearing the T-piece cap until you have delivered 5 inflation breaths. Each breath should be 2 to 3 seconds long, and you should see the baby's chest moving. The T-piece cap must be plugged or occluded for approximately 1/3 to 1/2 seconds. The lung inflation rate should be between 40 and 60 times per minute. Counting the following respiration cycle out loud will help you to maintain an accurate pace. Breathe, release, 2, 3. Breathe, release, 2, 3. Breathe, release, 2, 3. In this way, a frequency of 40 to 60 breaths per minute can be achieved. During inflations, the baby's chest should move in the same way it would if the baby were breathing calmly on its own. Remember that the lungs are only inflating if the chest is moving. Now, please pause the video and practice the actions outlined in this segment. Dry and keep the baby warm. Suction the airway if necessary. Then apply the mask and especially practice determining how and when to inflate the lungs. After you have given the initial set of 5 inflation breaths, reassess the baby's condition by listening to the heart rate, which should have increased, and look to see if the baby has started breathing on his or her own. If the baby's heart rate does not increase, and the chest does not move with inflation breaths, then corrective actions need to be taken. If the lung inflation procedure is not working, it can be improved by taking the following 6 steps, the corrective actions sequence. These steps can be easily remembered using this phrase, Mr. Soper. M. Mask adjustment. Adjust properly to the baby's face. R. Reposition the baby's head to open the airway. This is the most common reason why the chest is not moving. Remember to check the manometer reading. If the needle moves to 20 centimeters of water, then there is a good seal and the mask is fitted properly to the baby's face. Once the seal has been checked, try again to inflate the lungs. If these actions are not effective, then suction the mouth and nose. If the chest still fails to rise, try to inflate with the baby's mouth opened. If opening the baby's mouth is not effective, then increase the peak inspiratory pressure with caution. Listen and look to see if the chest moves. If these steps have not been effective, consider an alternative airway, endotracheal intubation or laryngeal mask. These procedures will not be shown in this video because they are advanced resuscitation techniques. Lastly, when should the lung inflation procedure be stopped? After each of the corrective actions has been taken, you must administrate additional breaths and then assess the newborn. Listen to the heart rate, which should be increasing. Check to see if the chest is moving and if the baby has established effective and regular breathing. Only if the baby begins breathing regularly or cries and the heart rate is 100 beats per minute or more, then you can stop providing lung inflations. Note that the baby must be continuously assessed by observing his or her breathing pattern. Now, please stop the video again and practice the 6 corrective actions discussed in this segment. It is vitally important that assessment of the baby's breathing and heart rate be performed immediately after delivery. Remember, if within the first 30 seconds after birth the newborn breathes regularly or cries, has good muscle tone, and the heart rate is above 100 beats per minute, then the baby does not need resuscitation. However, if the baby is not breathing or crying normally, has poor muscle tone, or a heart rate below 100 beats per minute, then lung inflation must begin immediately. Remember, the longer the baby is without oxygen, the greater the risk of brain damage, so decisions and actions must be taken rapidly. The first minute of life is crucial. The delivery room must be kept warm. Dry the baby thoroughly, remove the wet towel, and wrap him or her in a warm, dry towel to help maintain body temperature. Assess the baby's breathing, the muscle tone, and the heart rate. If you confirm that the newborn needs help, open the airway by positioning the baby's head on a neutral position on a plain and firm surface and give initial lung inflation using the T-piece resuscitator with a face mask. Reassess the baby after the first 5 lung inflations. Check to see if the heart rate is rising and see if the baby is breathing or crying. If heart rate and breathing are normal, then stop the lung inflation procedure. But if the baby does not establish regular breathing, you must take steps in order to improve the procedure with the Mr. Soper corrective action sequence. After either of these corrective actions, you must give 5 additional lung inflation breaths and then reassess the baby's condition by listening to the heart rate, which should increase, looking to see if the baby's chest rises and determining if the baby has established regular breathing.